Hello and welcome to today's presentation for Critical Care Services, Coding and Documentation. My name is Kristen Robinson. I am a coder, auditor, and educator and glad to be here with you today. Here's a little bit of my background in the areas I have previously worked in, as well as the specialties that I have experience in, including cardiology, critical care, pulmonology, vascular, and ED coding. First, we're going to start off with our disclaimer. CPT is a registered trademark of the American Medical Association. The information in this presentation is updated as of the current time and cannot be used as authoritative source as it is only for informational purposes. For the most up-to-date guidance, please reference your AMA CPT book that is most current to the time of your search. The presenter is not held responsible for misinterpretation of information. Today's agenda will include the critical care definition, time-based services for critical care, neonatal and pediatric services, Medicare guidelines, critical care when billed with other E&M services, critical care in the global surgery package, services that are both included and separately billable in critical care, as well as documentation coding tips. When we talk about critical care, the definition is that this is a direct delivery by a physician or other qualified healthcare professional of medical care for a critically ill or injured patient. A critical illness or injury is one of which that acutely impairs one or more vital organ systems, such as there is a high probability of imminent or life-threatening deterioration in the patient's condition. This involves high complexity decision making to assess, manipulate, and support vital system functions. This is to treat single or multiple organ system failure and or to prevent further life-threatening deterioration of the patient's condition. This requires full attention of the provider to direct management of the patient. Services to any other patient during the same period of time cannot be provided as they must be immediately available to this patient. So let's look at the vital organ system failures that are included here. So we see central nervous system failure, circulatory failure, shock, renal, hepatic, metabolic, and respiratory failure. Remember that no matter the failure, they still have to meet the critical care definition. So, critical care is normally provided in a critical care area, such as a coronary care unit, intensive care unit, pediatric intensive care unit, respiratory care unit, or the emergency care facility. But that does not mean they automatically qualify for critical care services, as they still must meet the definition for critical care. Also, there are times where critical care is performed on the floor outside of a critical care area. So just because they're outside of that area does not automatically disqualify them for critical care services, because yet again, it is based on the condition of the patient and the supporting documentation from the provider. Critical care can also be performed on multiple days, even if there are no changes made in the treatment. Just keep in mind that the same level of provider attention is required and documentation must show that it remains the same and the patient's condition is still dependent upon these interventions. So we're going to look at the two most used critical care codes. These are our 99291 for the first 30 to 74 minutes of critical care time spent. Then we have our add-on code 99292, which is each additional 30 minutes of critical care time spent. Remember, in order to bill critical care services, time must be documented. Now, there are occasions where one practitioner will begin critical care services and then there will be a handoff at shift change. If both practitioners are within the same specialty, same group, we can aggregate or add their time together to get a total amount of critical care time for that day. Now, also remember that when we add the time together, whichever provider performed the substantive portion or greater than 50% of the time spent is who we're going to bill the entire service to. Okay, so just remember that we add them together, and then whichever provider performed the greater amount is who's going to get billed for the entire service. Also, I would like to point out that there is a difference between CPT AMA guidelines and Medicare guidelines as it relates to critical care services. If you are billing based on CPT guidelines, as soon as your provider hits 75 minutes of time spent, you can bill 99292. If you are billing based on Medicare guidelines, Medicare requires the full additional 30 minutes, which would equal 104 minutes in order to get the first unit of 99292. Now we're going to dip our toes into pediatric and neonatal critical care. Now, this is a niche area where not everyone is used to billing these services, as they are only billable by the primary physician performing care to this neonatal or pediatric patient. Okay, these services differ in the fact that they are per day or per diem services, and instead of being billed based on time, these are being based on the age of the patient. So, when billing these services, keep in mind that any other practitioner outside of the primary physician will not bill these services, and these are only billable in the inpatient setting. These will never be billed in the outpatient facility or the office setting. So we start off with our first set, which is our 99468 and 469. This is for your initial and subsequent level per day for patients that are 28 days or younger. Their second set is 99471 and 472 for both the initial and subsequent. This is for patients 29 days to 24 months of age. And then lastly, we have our 99475, 99476, also for initial and subsequent levels for patients 2 to 5 years old. Now, once a patient hits 6 years old in the inpatient setting, at that point, all the providers are going to go back to billing 99291 and 99292. Now, if your provider is billing in the outpatient setting, whether it be place of service 22 or in place of service 11, they will bill 99291 and 292 across the board, no matter the provider specialty. So, here are a few of the common diagnoses that we may see in the critical care for a pediatric or neonatal patient. So we have acute respiratory failure. This is going to be one of which that may require high flow nasal cannula or HFNC. We have acute on chronic respiratory failure. This can include home ventilator or BiPAP, and the patient is in an acute need for increased respiratory support. We have acute cardiac failure, shock, acute kidney failure, which in the majority of adult patients, this would typically not fall into a critical care definition. But for pediatric and neonatal patients, these patients are much smaller. Their immune systems are not the same as an adult patient, and an acute kidney failure is much more serious in those patients other than adult patients, where it is typically not as high risk to the patient. We also have that I want to keep in mind normal chronic organ failure without an acute exacerbation, such as which the patient is on stable home ventilator or just awaiting coordination of discharge. This does not qualify for the critical care per the definition. So next we have our initial and continuous intensive care services. So you may ask yourself, what's the difference between critical care services and intensive care services? So critical care obviously must meet that critically ill or critically injured definition. Intensive care services are those of which the pediatric or neonatal patient no longer meets the critical care definition, but still requires more assessment and treatment than a patient that would be on the floor. That means that this patient is still sick. This patient is still needing constant assessment and treatment, but they just aren't critical care at this point. So, that being said, we have an initial followed by 3 levels for subsequent care. Again, this is only billable in the inpatient setting. This is for the primary physician providing care to the patient. No other providers of any other specialty will bill these services, and the initial level is billed based on age, and the other 3 levels are based on the weight of the patient. So our 99477, which is our initial level, is billed per day, and this is for patients that are 28 days of age or younger. 99478 is for a patient that is body weight less than 1,500 grams. 99479 is for body weight of 1,500 to 2,500 grams. And then finally, we have our 99480, which is for patients of 2,501 through 5,000 grams. If you are a coder that educates your providers, please ensure that your providers are documenting the weight of the patient. Some of the diagnoses that we may see in the intensive care unit would be neonatal fever, sepsis, hyperbilirubinemia, respiratory distress, acute respiratory failure, tachycardia, and tachypnea. Remember, this is not an all-inclusive list. This is just some of the most common diagnoses that we see. So, specifically for our pediatric and neonatal patients, there is a code set for critical care during transport. This is specifically for patients 24 months of age or less, and this is when a patient is being transported from one facility to another facility and they require care during transport. So, this is billable only by the physician that's providing the hands-on care to the patient, and they must spend 30 to 74 minutes to get that level 99466. In order to get the 99467, they have to meet an additional 30 minutes of hands-on care. And again, just like with regular critical care, any time less than 30 minutes is not separately reportable. So, Medicare guidelines for our APPs. So, this is for your nurse practitioners and your physician assistants. Remember that they have to be within their scope of practice. So, that means that APP has to be able to bill critical care services before they ever perform them. They need to make sure that they are within their scope of practice and licensure requirements for the state in which they are providing services. Also, remember collaboration with the supervising physician, and they have to meet the billing requirements in order to also bill critical care. For our physician assistants, they still have to meet the general physician supervision requirements. So, we're going to talk a little bit about split shared services. For anyone that's not familiar with split shared services, these are for hospital visits only. If you are performing services in the outpatient office setting, it would then be incident 2 services, and incident 2 is never performed inpatient, and split shared services are never performed in the outpatient office setting. That being said, we are specifically discussing inpatient services for today's presentation. So, when we are talking about critical care split or shared services, this is when a mid-level or an APP, an NP or PA, is providing services with an MD. So typically what happens is the APP will go in, start the note, see the patient, provide their MDM assessment and plan, and then the MD will come behind them, provide an attestation with their portion of that patient's care. Specifically with critical care services, because these are based on time, how we bill the substantive portion is who spends greater than 50% of the time spent. So you're going to aggregate or add the time that the mid-level spent to the time that the MD spent, and you'll have a cumulative amount of time. Whoever spent the greater than 50% of that time is who you're going to bill the entire service to. Now, when you are billing split shared services, you need to make sure that you append the modifier FS. This tells the insurance that this was in fact a split shared service. And keep in mind, it does not matter whether you inevitably bill under the mid-level or you bill to the MD, you still must append the modifier FS. So here is a chart breaking down the different guidelines as far as billing critical care services. So to your far left, we have the CPT, we have our Medicare, and then we have our across the board. So when I say that, I mean less than 30 minutes across the board is still an appropriate E&M level and does not qualify for critical care. 30 to 74 minutes, both CPT and Medicare agree that this is a level 99291. Where they differ is when it comes to our units of the add-on code 99292. So if you are billing based on AMA CPT guidelines, once you meet 74 minutes through 104 minutes, you get that first unit of 99292. If you are billing based on Medicare guidelines, you must meet the full 104 minutes to get that first unit of 99292. And it just goes on from there. 105 to 134 minutes, you're going to get 2 units for the AMA CPT guidelines, or you have to meet 134 minutes to get that second unit of 99292, and the list goes on. So when we are talking about Medicare guidelines, okay, so if you have a single practitioner or concurrent care by providers in the same group, same specialty, Medicare requires that full additional 30 minutes to get that first unit of 99292 and so forth, which we mentioned on the previous slide. So remember that this is a deviation from CPT AMA guidelines. Now, for split shared critical care, each unit of 99292 is a partial increment of 30 minutes, which is same as the CPT guidelines. So now we're going to talk about critical care when billing another evaluation and management service on the same date of service. So there is one very specific rule when it comes to billing critical care services on the same day as another evaluation and management service. So if the patient comes in to the hospital and they start off non-critical, so that means they're seen for a regular evaluation management service, and later on that day, it could be an hour, it could be 5 hours, it doesn't matter, but on this same date of service, this patient falls into a critical care status, whether this be severe altered mental status, a heart attack, a stroke, ventricular fibrillation, cardiac arrest, whatever the case may be, the patient now meets the critical care definition. So your provider is now going to bill for however much time they spent performing critical care to that patient, as well as any other separately billable procedures if applicable. Now, when we bill this, you have to make sure that you are not overlapping care. The earlier visit was for whatever they were originally being seen for, and the critical care time is being billed for what they developed later on that day. So when you bill this, make sure that you append your modifier 25 to your other E&M service that signifies that it was in fact a separately identifiable E&M service on the same day as the critical care services. Now, when it is not appropriate to bill both visits, if the patient starts off critical and improves throughout the day, and that provider just happens to see that patient in rounds later that day, or for whatever reason, that other E&M service is not separately billable. When we talk about critical care in the global surgical package, so if your provider group specialty performs a procedure that puts a patient in a 90-day global package. So, for instance, let's say you are billing for a cardiovascular thoracic surgeon, or what we call CVT, and they do a CABG, which is a coronary artery bypass graft. This has a 90-day global period. The normal follow-up for a patient after a CABG has been performed is typically they will be sent to the critical care unit for a couple days to recover and be tightly monitored for pain management and other normal post-op follow-up. Now, let's say that same provider or another provider in the same practice, same specialty, has to see that patient for critical care outside the normal post-op follow-up, such as severe respiratory distress or altered mental status. And again, it could be a heart attack, it could be a stroke, it could be any other condition that would qualify that patient for critical care services outside the normal post op follow up. So, in these cases, if the provider seeing the patient is within the same specialty as the provider that performed the global surgical service, then they have to make sure that when they bill that critical care service, they append the modifier FT. Now, the modifier FT does not apply to any other provider in any other specialty. We would only append the FT modifier for a provider that is within the same specialty and group as the provider that performed the surgery. When we talk about critical care and teaching physicians, so if you are used to billing for teaching physicians in your local facility, you know that for all other evaluation and management services, that the teaching physician is only required to be available for the key elements or certain very important parts of the evaluation and management service. They still have to provide an attestation, they still have to sign off on the note, but that differs when we start talking about critical care services. Because with critical care specifically, if the provider, the teaching provider, is not physically present when the resident is evaluating this patient, anytime they are not physically present, you cannot bill for the time spent by the resident. So, for instance, in order to bill 35 minutes of critical care time, the teaching physician would have to be in the room during the entire time the resident performed the service. So if the resident went in 10 or 15 minutes earlier, that time just doesn't get counted. Also, remember that just like with your other evaluation and management services, the provider still has to provide that attestation at the bottom of the note. They need to be telling us what put the patient in this critical status, what was going on during that time of service to require the nature of treatment or other assistant or assessment and treatment to that patient at that time. So, an acceptable documentation example would be the patient was hypoxic and hypotensive. I spent 40 minutes of time with this patient in this condition. Remember, this is the teaching physician's attestation. Treatment included IV fluids, pressor drugs, and O2. The resident's assessment and plan of care was reviewed, and I agree with their documentation. So that means that we get to bill 40 minutes of critical care time for this patient. Again, any other time outside of this that the resident saw the patient without the teaching physician would not be billable. When we look at procedures that are inclusive to 99291 and 99292, and this also applies to your pediatric and neonatal critical care patients, this list is in your book for complete reference, but just for today's presentation, I would like to go through these just to present why we include these. So there are general practices and treatment that is common. It is general, meaning they are commonly done and it is not outside the norm of a separately billable procedure. So this includes interpretation of cardiac output measures, chest x-rays, pulse oximetry, hematologic data, gastric intubation, temporary transcutaneous pacing, ventilator management, and vascular access procedures. Now, some of the most common separately reportable procedures, and again, this is not an inclusive list. The previous slide was a comprehensive list of what CPT states is inclusive. Now, this list is only the most commonly separately billable procedures. That means there is a possibility of other procedures not listed on this slide. So first off, we have CPR. This is our 92950. I want to be very specific here. This is only billable while being performed. Okay? Because CPR is separately billable, you cannot count the time spent performing CPR in the critical care time spent. There is an NCCI edit that says 99291 and 92950, the time spent devoted to performing the cardiopulmonary resuscitation shall not be included in the critical care E&M service time. So your provider must document that they carved out the time spent during CPR out of the critical care time they reported. So the most common thing that a provider will put is the critical care time was spent outside of any separately reportable procedures. Okay. We also have endotracheal intubation, which is our 31500, central line placement 36555 and 556, intraosseous placement 36680, tube thoracostomy 32551, temporary transvenous pacemaker, which is 33210, a electrocardiogram, this is your 12 lead interpretation and report only, 93010. And then I want to stop on this last one, an elective electrical cardioversion. This is code 92960, but I want to make a very clear distinction on this one as well. By definition, 92960 is for an elective electrical cardioversion. Elective means that the patient was able to give consent to the procedure. If an electrical or chemical cardioversion is performed in a critical or emergent state, that patient is not going to be able to give consent to the procedure as a life-threatening situation is going on that must be performed emergently. Okay, so in those cases, because it is not separately reportable, they can add that to the critical care time. I have also included the NCCI Policy Manual, Chapter 11, page 13, states that if a cardioversion is emergent, it cannot be coded separately. Okay. So, for any other procedures that can be reported separately, make sure that you append modifier 25 on the critical care services billed on the same day as these procedures. So now let's look at some documentation tips. So we have make sure that the documentation supports how critical this patient is at that time of service. Okay. Make sure that your providers are documenting the fullest specificity of the injury or illness that affects at least one organ system. They need to be documenting the high specificity to paint a complete picture of the condition of the patient. So, for example, I don't want to see respiratory failure unspecified. If a patient is in critical care, they need to make sure that they are actually critical. So, across the board, across all specialties and documentation, we always want to have the providers not only document at the high specificity, but we want to capture the high specificity diagnosis code. So instead of the provider documenting simply respiratory failure, we need to see, is it acute? Is it chronic? Is it acute on chronic? Is it hypoxic? Is it hypercapnic? We need to know the full picture of the patient's critical condition. We want to make sure that they are using documentation wording such as high probability of deterioration, or that the condition would worsen significantly without the provider's intervention. We need to make sure that they indicate what treatment or management is being provided that meets this high complexity decision making. We also want to make sure that they watch their wording as it states stable on ventilator, or maybe instead of saying that, we say consistently requiring ventilator. So basically, what that means is stable means they're improving. They may be ready to be transferred out or onto the floor, but consistently requiring ventilator is showing that they are still at that high level of care that is necessary for a patient in a critical care state. So again, we want to make sure that the provider is performing their full attention to this patient for the critical care time documented. They have to be immediately available on the bedside, floor, or unit if they are seeing another patient, if they are on another floor of the hospital, if they went to their car to eat lunch, if they ran across the street to their office practice. None of these will qualify for critical care time. So, make sure that your providers are documenting the activities directly contributing to the patient's care. They need to make sure that the critical care time is clearly documented. There are certain insurances that want start and stop times. Now, I get this a lot from providers that they feel that it's inappropriate that they should have to use like a stopwatch every time they walk into a patient's room. But ultimately, this covers the provider as well. This is proving when were they seeing that patient, not just how much time they spent with the patient. We also want to make sure that if they're not using start and stop times, they're giving us the closest amount of time that was actually spent with that patient. Okay, and we'll talk about some other red flags here in a few minutes. So, they need to use a statement noting the time of critical care documented and make sure that they carve out any time spent on separately reportable procedures. Okay. Also, it would be best practice that they state that it was dedicated to this patient services only. Sometimes critical care services overlap 2 calendar days. Per the Medicare Claims Processing Manual 30.6.12, it states that if the time is continuous, that means there is no break in time from the first date of service to the second date of service, then you can bill it as if it was one date. and you would bill the appropriate 99291 and 99292 based on time documented. So, for today's example, if a provider spends critical care time from 11:15 p.m. to 12:45 a.m. the next day, that 89 minutes of critical care time that is continuous, you would have your 99291 and then your 99292. Remember, this is based on AMA CPT guidelines, not Medicare. If you are billing based on Medicare, you would only get the 99291. Okay, now we have how do we bill it when it is not continuous? So, when time is not continuous, for example, they started the critical care on June the 12th from 11:15 to 11:58 p.m. That's going to be billed as a 99291 for that date of service. They picked up critical care time on June the 13th at 12:05 a.m. through 12:45 a.m. That's a second 99291. You're going to get the first one for the 12th and the second one for the 13th. Some providers want to cram this all into one document. I highly recommend, as a best practice, that if it is not continuous, that they do two separate notes to completely identify that it is two different dates of service. In the case where your provider does not split the notes up and they put this on one note, they have to clearly document what was done on the first date of service and what was done on the second date of service, and they must label when the first date of service started and ended and when the second date of service started and ended. And this is best practice so we can show a clear representation to the insurance. Also, of course, just remember that they have to date and time. So, a few other documentation tips. Some of these are common knowledge, but I still like to state them. Remember, if it's not documented, it didn't happen. If it is not signed, it's not billable. If it is lacking a teaching physician attestation for the cases in which we are billing for a teaching physician, you cannot bill for services that are not directly with the resident and teaching physician present at the same time. Okay, so again, time spent must be separately reported from any procedures also billed on the same day. So now we're going to get into a few auditing concerns, and I'm going to cover a couple other inappropriate scenarios. So when I am auditing a chart, or if you have an outside audit or an insurance audit of your practice or your facility, wherever it is you work, we are going to be looking at the documented time spent. Okay, so a huge red flag is an extensive amount of time on one date of service. For example, if you saw 10 to 12 hours exceeded, this is a huge red flag because unless your provider is performing services to a specific condition, such as like heart transplant, lung transplant, a patient being on an ECMO device, or some other severely extenuating circumstance, the majority of the time, providers are not going to be spending an extensive amount of time on any one given day. Not saying that it could never happen, just saying it's out of the ordinary. We also see a lot of template misuse. So, this is when if you are auditing the chart, even if you're coding the chart, if you are doing multiple days at a time and you see that either the same time on every patient or every day on the same patient, the same time is spent, this is also a huge red flag because I can guarantee you that the provider is not spending 35 minutes on every single patient they see that day, or they're not spending 35 minutes on every single day they see a patient. So remember, when auditing happens, there is a possibility, especially with insurance audits, of time study being done. So what they do is they'll look at the time the provider was actually in the hospital seeing patients, and then they look at how much time they documented for all of their notes on that date of service. And if the times don't match up, they're going to be in some hot water. So if the provider was in the hospital for a 12-hour shift, and if you added up every note from the patients they saw that day and it equaled 14 or 15 hours, they would have some explaining to do. So we need to make sure that our providers are accurately documenting the closest amount of time spent, with best practice being start and stop times. We do not want to see the greater than sign, the less than sign, approximately, or whatever synonyms you want to use there. Those should not be used ever. I don't want to see greater than 30 minutes or less than 74 minutes. I need to know, did you spend 38 minutes? Did you spend 69 minutes? We have to have the closest amount of time that the provider has knowledge of at the time they saw the patient. Okay, so a good example of a clear statement: I spent a total of 81 minutes providing critical care services for this patient on this date of service, not including any separately reportable procedures. Now, remember, even if your provider does use a template, they need to edit the time to be unique to every patient encounter. They need to edit exactly what services were provided to that patient on this date of service. They could identify the patient's name, whether it be their last name or whatever the case may be. They need to put that date of service for that patient. And best practice would be to list what other procedures were performed on that same date of service. So again, missing or inaccurate time. Remember that if you are reviewing a note for a patient and they meet the critical care definition, but your provider did not document time, if you do not get an addendum pre-bill, the majority of insurance companies will not allow you to provide an addendum and then rebill it or be able to appeal it. So, that being said, if you review a note and you can see clearly that this patient meets critical care by definition and the provider has not documented the time, make sure you query your provider to get them to provide that addendum. Now, if you work in a practice or a facility where you do not have direct access to your providers and you must bill based on the documentation provided, that means that if critical care time is not documented, it would then fall back to the appropriate E&M level based on medical decision making. Also, remember, again, I mentioned this at the very beginning of the presentation, that just because a patient is in a critical care area does not automatically qualify them for critical care services. We also make sure we want to see the proof that they are critical. What organ system is failing? What was done to prevent death? Again, with template overuse, providers sometimes want to take the easy route, copying and pasting the assessment and plan day over day. When I used to code for critical care, I would ask my providers that if nothing else, they provide me a daily update. It could be a few words, it could be a sentence or two with that date of service. So if they see the patient 612, 613, 614, 615, each day will have that day's update. Even if no changes are made, they're telling us this patient is still requiring this same level of service today. And again, if you are seeing general statements on all patients, so they use a template and they make absolutely no changes to specify this unique patient on this unique date of service, that is a huge red flag and should be educated as soon as it is found, because we do not want our providers feeling like this is acceptable and then wondering why they get in trouble if they get an outside or insurance audit. So, lastly, we're going to cover a couple of inappropriate scenarios followed by a couple of appropriate scenarios. So, when we talk about inappropriate scenarios, it could mean that it doesn't meet the critical care definition. They didn't give us the required amount of documentation, or there are a couple outside instances that this could apply, one of which I'm going to be referencing in just a second. For our first example, this one states, I provided critical care services from 10 a.m. to 12 noon. So, why is this not appropriate? The provider gave no detail as to what was done. Were there any breaks? Was it continuous care? And whether any other procedures were included. Our second inappropriate example would be, I, Dr. Lyons, provided critical care to this patient between 9:05 and 9:27 a.m. on data service 9/19/2024, not including procedures that were separately performed. So, why is this not appropriate? Because if you simply look at the attestation, it looks like a great form of documentation. But this particular instance, the provider spent less than 30 minutes of critical care time. And as we already know, less than 30 minutes would fall to a subsequent level of service. So, our last couple are our appropriate scenarios. So, our first one will be, I, Dr. Lee, spent 45 minutes of critical care time from 6:40 p.m. to 7:25 p.m. on 2/25/2025, monitoring pressors, IV administration, and O2 levels. Time spent was separate from any other procedures billed. So, why is this appropriate? He told us how much time. He gave us start and stop times. He gave us the data service and that it was done outside of any separately reportable procedures. Our last example is, I performed critical care service from 7 a.m. to 8:30 a.m. The patient was in an altered mental status and found to be in VFib, or ventricular fibrillation, cardiac arrest. Patient was cardioverted and brought back to rhythm and then transferred to the ICU for further treatment and monitoring. Why is this appropriate? They gave us the timestamp. What was done? The cardioversion was emergent, so it can't be reported separately. Therefore, because it is not elective, it can be included in the time spent for critical care. So, I hope everyone enjoyed today's presentation. Here are the resources used, and I hope everyone has a great rest of their day.